Good afternoon, students, and thank you so much for joining us with this session. We are discussing mood disorders and us as South Africans. The question we will be asking today is, can we curb the delay in, if not the lack of seeking treatment? You have two presenters today. It will be Ms. Lerata Wana. She's a counseling psychologist and the manager of student counseling development on the Mafeking campus. And then myself, Ms. Ilana Kutsia, also a counseling psychologist, and I work at student counseling development on the Potchefstroom campus. Our outcomes is just to give you a little bit more insight into mood disorders, specifically mood disorders like depression, bipolar 1, bipolar 2, and then bringing it home to mood disorders South Africa. We'll be giving a little bit of scientific research and then focusing on the Black South African community, ending off with how we can bring it all together. We're excited that you'll be journeying with us on this exciting topic. Right, so what is mood disorders? Today we're going to view human beings from the biopsychosocial model. The biopsychosocial model look at the interconnection between biology, that's our physical bodies, psychology, our emotions, our mind, our psyche, and socio-environmental factors, society, culture, and our spiritual beliefs. The first section will just be the psychology part of humans, so that's focusing on mood disorders itself. And the second section will be bringing in the socio-environmental factors influencing us as humans. So, if we look at mood disorders, we have to start with emotions as human beings. So emotions is something you know very well. That's what we feel and kind of how we evaluate our lives. And psychologists have brought it down to 10 basic emotions. So it's joy, surprise, sadness, anger, disgust, contempt, shame, fear, guilt, and interest or excitement. There's a lot more that stem from these 10 basic emotions, as you know, and you're welcome to play around with them and explore them even more. But today we want to focus on moods. So moods is longer-term emotional states. This brings us to mood disorders. So mood disorders is when your moods, that is longer-term emotional states, is not what you want it to be anymore, and it is causing harm. So mood disorder is usually longer-term. It is psychological of nature, and it can be termed a psychological disorder. So looking at one of the most well-known mood disorders, looking at depression. Now, first of all, to say what depression is not, is it is not sadness or just going through a rough patch. According to the medical news today, sadness is a normal human emotion that every single person will experience at stressful or somber times. And sadness, which differs from depression, is a human emotion that is normal to experience during stressful or gloomy times. As we go through difficult circumstances, we are prone to experience sadness, which is the mind's way of telling us that our normal coping mechanisms is under attack. A number of life events can leave people feeling sad or unhappy. The loss or absence of loved one, financial trouble, or issues at home can all affect mood in a negative way. However, a person experiencing sadness can usually find some relief from crying, venting, or taking out frustrations. More often than not, sadness has links to a specific trigger. Sadness usually passes with time. If it does not pass, or if the person becomes unable to resume normal functioning, this could be a sign of depression. Depression is a serious mental health condition that requires understanding and medical care. Depression is an illness characterized by persistent sadness and a loss of interest in activities that you normally enjoy, accompanied by the inability to carry out your daily activities for at least 2 weeks. But there's various symptoms which include anxiousness, feeling empty, feeling nothing, feeling sad, hopelessness and worthlessness, being irritable much of the time, withdrawing from others and preferring to be alone, dropping in your grades, a loss of interest or pleasure in activities, eating or sleeping habits that's increased or decreased, feeling tired or like you have less energy, trouble concentrating or remembering information, and increased thinking about dying or suicide. It is very important to note that depression has to be diagnosed by a professional. This is a psychologist, a doctor, or a psychiatrist. If you think you might have depression, please seek professional help. To continue from depression, there is 4 types, a little bit more, but 4 types I can mention today. So that is the disruptive mood dysregulation disorder, major depressive disorder, the one I just explained to you, persistent depressive disorder or dysthymia, and premenstrual dysphoric disorder. I'm not going to go into the details of these, but you can just take note of them. I want to move on to another type of mood disorder, and that is bipolar disorder. What is bipolar disorder? Recently, we started to speak about being on the bipolar spectrum, and bipolar disorder can show first as depression, mania, or hypomania. So there's three different types. We've got bipolar 1. This involves periods of severe mood episodes from mania to depression. Bipolar 2, which is a milder form of mood elevation involving mild episodes of hypomania that alternate with periods of severe depression. And cyclothemic disorder, which is numerous periods with hypomanic symptoms and numerous periods of depressive symptoms for over a 2-year period. So to explain a little bit better, mania this is usually the defining characteristic of bipolar disorder. Without mania or manic episodes, you cannot diagnose a bipolar disorder. To give you the exact terminology, it is a distinct period of abnormally and persistently elevated, expansive, or irritable mood, along with abnormally and persistently increased activity of energy, lasting at least 1 week and present most of the day and nearly every day. It could be any duration, and especially if you have to go to hospital. So the focus here is an increase on energy, activity, excessive and abnormal behaviors, grandiosity, pressured speech, flight of ideas, lots of different symptoms, with the big focus being on the mood and the energy that's increasing. Hypomania, on the other hand, is in a constellation of manic symptoms lasting at least 4 consecutive days. These are less severe manic episode symptoms. And then depression, in this context, is called unipolar depression, is the low moods that are identical to major depressive disorder. I'm going to show you a quick video that explains this very, very well. So just move with me.
One way to understand these swings is by charting them on a graph. So let's say that the y-axis is mood, with mania and depression being on the far ends of the axis, and the x-axis is time. The average healthy individual might have normal ups and downs throughout their life, and they might even have some pretty serious lows once in a while, maybe after losing a job or moving to a new place and feeling lonely. An individual with unipolar depression, though, might have normal highs, but they'll probably also have some crushing lows that last for a long period of time and might not even have an obvious trigger. Now, for the bipolar disorders, the first one is called bipolar 1. And these are people that have some major lows that last at least 2 weeks, and then some major highs that last at least a week or require hospitalization. That said, untreated manic episodes can last as long as 3 to 6 months. And even though depression is seen in most cases, it's not actually required for a diagnosis. The second one is called bipolar 2, and this is when a person experiences similar lows and has additional highs called hypomania, which are less severe manic episodes than we see in bipolar 1. To qualify for a diagnosis, these hypomanic states need to last for at least 4 days. Once again, though, these symptoms generally last a few weeks to a few months. Alright, and the third one's called cyclothymia, or sometimes cyclothymic disorder. And these people have milder lows as well as milder highs, or hypomania like you see in bipolar 2. And they cycle back and forth between these two over a period lasting at least 2 years.
This is what the video was going to explain. So just to say to you, as an average person, that's the green dot. If you look at the green line, we do all experience different emotions and moods. We do get high moods and we do get lower moods, which is normal for us as average persons. Unipolar depression then is with the bipolar depression only with depression symptoms in the beginning, experiences some, or not full mania, but some mania, and then goes down to depression. And then we've got the bipolar 1 in the light purple, as you can see, just follow the graph there, which is more, where's that 1 or 2 weeks of depression, more or less, and then also going right all the way into mania. And then we've got a bipolar 2, which hits also depressive episodes and hypomanic episodes. So it's not all the way to mania. And cyclothymia, which you can see then, is a recurring of the depressive episodes and the mania and the manic episodes over a period of 2 years. So these are quite complicated, but actually quite easy to understand terminologies. The reason we're telling you this is just to give you a little bit of background behind it, to say that it is scientific and these are diagnosable disorders. So again, please don't self-diagnose. If you have any questions regarding this or suspect you might have it, then please visit your nearest professional. I'm going to hand over to my colleague now to continue with mood disorder in South Africa.
Thank you, Ilana. Good afternoon, everyone. Thank you so much for this opportunity to have this very important discussion with you. I specifically requested my colleague that I cover mood disorders in South Africa because I think South Africa is a fertile ground for mental illness due to all the psychosocial problems that we have in the country. And I specifically want to zoom in with the Black South Africans, although I think some of the things I'll be talking about can actually happen to all of us and not just the Blacks. We can change. Culture. What comes to mind when you think of culture? For many of us, if I can just think of myself off the top of my head, I usually just think of what's in front of me, the language, clothing, the food that I'm eating. However you may think of culture, you may just remember that it impacts the way it impacts your beliefs, it impacts your norms, it impacts your values, it impacts your views and your ideas. And with regards to mental health, it impacts whether or not you seek help. It impacts whether it impacts the way you're going to seek help, the type of help you're going to seek, and also the kind of support that you're going to surround yourself with in order to assist you when you're having distressful time. Next slide. Scientific research, especially in the US, when we speak of minorities, we're speaking about the Hispanics and the African Americans. They've been reported to not seek mental health support or wait until the physiological symptoms are severe before seeking help for help that would help them attend to the physiological symptoms. And when Ms. Ilana was speaking, she spoke about the biopsychosocial model, the biology part. When I speak of physiological, I'm speaking about the biology part. So the headaches and the other symptoms that you would have, they are then known to only seek help when those symptoms are actually quite severe. When we look at the Asians, they've been reported as a cultural group that has the lowest rate of seeking general medical care, let alone mental health care. And we all know the Asians are very big on the herbal medication, the meditations. In South Africa, we reported to be attracted to also other means of coping mental illnesses rather than the conventional medicine. And when I see a statement like that, I'm then asking myself, so what are we doing? If we are fertile ground for mental illness and we're not seeking the conventional assistance, what are we doing instead? Next slide. Let's zoom into the South African community. Let's have a look at what they're doing instead of going to the conventional medication. Next slide. Depression amongst Black South African is deeply misunderstood. And I think our point of departure in dealing with the misunderstanding is that we need to start talking the truth about the myths. And in turn, this should probably change everything that's around us and the stigma as well. Because it's the stigma that paralyzes us. And when we are paralyzed, we then stop and we start to look for other options for appropriate help. South African researchers have reported that only 8.5% of Black South Africans who reported 2 or more years of depressive symptoms have been in contact with mental health professionals. That's only 8.5% who have said anything to a psychologist or a psychiatrist. What are they doing instead? South Africa is known for our traditional work. So we've got our traditional healers. Many of us are going in that route. And I want you to think about this under the umbrella of mental health, not physical health. So we're going that route as well to look for assistance. Next slide. Some of us are going to our churches. There's a lot of pastors coming up. There's a lot of non-denominational churches coming up. Others are even going as far as meditation and the whole concept of mindfulness and spiritual search for oneself to deal with mental illness. Other people are looking at medicinal assistance. We're looking at herbs. This is something that's very, very popular amongst the Black South African community. Going out and getting some form of herbal medication to assist you. And most of these are actually also prescribed by the traditional healers. Next slide. I'd like to think that there are barriers. It's not the individual's fault. It's not the South African's fault. that they're actually looking for alternatives to deal with the mental health. Us as professionals as well, we are not equipping ourselves to deal. Some of the barriers that are between the patient and the mental health practitioner. Our patient, their lives, their work, their function, their understanding is guided by their social and cultural life. And that's versus us as mental professionals who we are guided by a big Bible called the DSM-5. And I'm talking specifically about the mental health professionals. The psychological symptoms are classified in the DSM-5. They are categorized in the DSM-5, whereas a patient will view their life very liberally and very broadly. Mental health professionals separate spheres. Ms. Ilana spoke about biopsychosocial. I'll refer to that again. The biological, the psychological, and the social. As a patient, we're not breaking it down into the three. We are one. And that's what I mean when I speak about dichotomy. We're not breaking it into the mind, body, and soul. Many of our cultural experiences, we're not taught to separate our mind from our body, from our spirit, from our soul. We, Black South Africans, they view their distress in a very spiritual manner. So, for instance, it could be because I have not done something and the ancestors are angry at me, or I have not done something and I need to go to the church and sort it out, or speak to my pastor and sort it out. And that's a barrier. Next slide. Language is also something. We are taught to be psychologists in a particular language. The population that we work with has a totally different understanding of the work that we are doing. So, for instance, if I just had to think of myself as a psychologist, if I'm dealing with somebody who has no understanding of psychology, the first thing when they come is, Ms. Ilana spoke about depression not being sadness. Their first thing is not going to say, I'm sad. In the African community, they speak metaphorically and symbolically. They describe what they're feeling. So phrases like, I'm not feeling like myself. Oh, this is over and above the physiological or somatic complaints that they have. Just as general not knowing what's going on with them would give me an idea that this is a little bit more than just a physical condition that's going on. When I speak of artificial overview of social or challenges in the social system, this would be somebody who would then walk in after mentioning that they're not feeling like themselves, and they would describe what's going on with them. They would then begin to describe challenges in the workplace with a colleague, or challenges at home with a partner, maybe family issues or family system issues. And when like I said, metaphorical and symbolic description. So this is what would give me the clue as a professional that this is definitely what's happening with the patient sitting in front of me is definitely much bigger than just a simple headache or just a simple chest pain. Next slide. How do we bring it all together? As professionals, I believe that it's important that we increase the knowing and understanding of the community that we're in contact with. My name, I'm Leratowana, I'm on the Mafeking campus. I need to understand that majority of the students on our campus are Black students. They're coming from all over the country, as far as the Mpumalangas, as far as the Limpopos, the Vendas, the KwaZulu-Natal. These students are coming onto this campus and they all have beliefs and attitudes and health practices coming from home. They want to come onto campus and they'd like to continue those practices as best as possible. I, as a professional, it's my responsibility to try and understand where they're coming from and how they view mental illness. Next slide. As a patient, how do you bring it all together? And this is quite important. This is something that I had to really, really think about. I don't believe as a professional that just because I'm a psychologist, I should cut out all the non-conventional methods. I would bring it all together. So yes, let's go to the doctors, let's go to the psychiatrists, let's go to the psychologists. But there's an element, the traditional stuff does help. It's according to your belief. The medicines, the herbal medicines that people are taking, if you believe it, it probably will work for you. I am not in a position to say it doesn't work. So I believe that we should actually bring it all together. do what you need to do culturally, but also don't forget that there's also this aspect of the conventional assistance where you can get from the professionals. I want to say to patients, you've got nothing to lose but your mind. Literally, coming out and speaking to psychiatrists or seeking psychological help with a psychologist like myself and Miss Ilana, you've got nothing to lose. If it doesn't work, then you've lost nothing. You go on to the next alternative. What's going on in your mind is just as important as what's happening with your body. I mentioned in the beginning, and also research has indicated that a lot of the minorities, a lot of the Black South Africans, a lot of the minorities in other countries are treating the symptoms. They're treating the way they feel physiologically. And it's all connected. You could be experiencing something emotionally, experiencing something socially. It will affect your physical. So it's all connected. The other is not more important than the other part. So dealing with a headache is important, but the fact that there is this challenge, the lack of sleep or the relationship problem, that's also an important aspect of you that also needs to be attended to. Otherwise, the headaches or the lack of sleep may not stop. If it doesn't go away and you don't seek alternative options, it can only get worse and have dire, if not fatal, consequences. And what I mean by if it doesn't go away, if the alternative, the non-conventional, does not work, I'll go back to my second phrase, you've got nothing to lose. Please go out and try alternative. Come and see if the conventional will work for you. There are many of our students still on our campus that are still very, very, very cultural in the way they're thinking. It's not a bad thing. But if you find that the way you're feeling is not getting better, make your way. You've got nothing to lose. Come to our campus, come to our SCD centers all around the institution and the Botch and the VAL. Ask for alternative assistance. Let's talk about what's going on. Let's see if we can help from a different perspective. That's all I'm saying when I talk about how do we bring it all together as, from the patient perspective. Next slide, I think that's almost it. Where to find us? This is literally where we are on each campus and our contact details on each campus. Miss Ilana is on the Potch campus, I'm on the Mafeking campus, on the Vaal campus. We've got specialists just like us. The manager there is Mr. George Damani. Let's go out there, let's get help. If you can't find way out where we are, but you know where the campus clinic is, go to the campus clinic, they'll make a referral to us, or vice versa. But please do not sit in your room thinking that there is no help. There is help. And that's where we'll take it. We'll take it client-centered. We can't really give out a general intervention plan for everybody. Everybody's going to be treated according to what it is that they bring that would be the challenge in their life. Next slide. Great. This is the end of us. I would like to hand over back to CTL for further coordination of this webinar. Thank you so much for listening. If there's any questions, we are right here, Ms. Ilana and myself, to answer.